Welcome to the International Women's Day webinar of the World Federation of Hemophilia. Our title today is Bleeding Disorders and Reproductive Health, Disparities in Treatment and Care. My name is Dawn Rodolini, and I'm the Chief Operating Officer of the National Hemophilia Foundation in the United States. I'm a WFH board member, and I'm the chair of the Women and Girls with Bleeding Disorders Committee. It's my pleasure to welcome you here today to celebrate International Women's Day. Next slide, please. So we're here together to celebrate. I'm so excited that you're all here with us. It's such an important topic, and we are here to learn so much. Let's go to the next slide, please. So just please, for housekeeping, as you can see on the screen, please select your language of preference now. Click on the three dots to select the interpretation channel. And then if you'd like to ask a question, please select the Q&A icon. This could potentially be at the bottom of your screen. If you're on a laptop or on your phone, you'll be able to see it as well. Next slide, please. For mobile phones, you can see it's on the very far bottom side. There's those three little dots. Please click on those, select the interpretation channel. And then you can see on different kinds of mobile phones, it's in a different location. Click on your language of choice, as you can see on the screen, and then click Done to select your language. Next slide, please. As you can see on mobile phones, you'll have a little Q&A button on the bottom, and please select that to type in your questions. You can do that throughout the presentations, and we'll address questions at the end. Next slide, please. So here's our agenda. I'm so excited. So we'll have welcoming and remarks. Of course, we've just done that with housekeeping. We'll talk about fertility issues for women and girls with bleeding disorders from an OBGYN point of view. And that will be Dr. Maureen Baldwin from the US. And then we'll hear from Marianne Broer from Austria about her experience of living with a bleeding disorder. And then we'll have a wonderful presentation from Dr. Claudia Kayat from Lebanon on management of women and girls with bleeding disorders in multidisciplinary sessions. And as I said at the very end, we will have our Q&A period. Next slide, please. So we'd like to ask you to rate your knowledge and skills in the following areas. So please take a moment and answer the question that's in front of you. As you can see, we'd like to rate your knowledge. Number one, bleeding risks during pregnancy for women and girls with bleeding disorders. Please select your level of knowledge. Very poor, meaning you need to learn a lot about it. Poor, fair, good, very good. I have a pretty good understanding of this. Or excellent. I am an expert in this topic of bleeding risks for women and girls with bleeding disorders. Please select where you feel that you're at. And then number two, what is the 722 rule? Do you know? What is your level of knowledge and skills in this area? Do you know what it is? So is it very poor, poor, fair, good, very good, or excellent? And then number three, what are the main causes of maternal death? What is your level of knowledge and skill in this area? Very poor, poor, fair, good, very good, or excellent? Menstrual bleeding assessment, PBAC score. Do you know what that is? Is your level of knowledge and skill very poor, poor, fair, good, very good, or excellent? And then finally, the last question, multidisciplinary team management. Do you know who needs to be on that multidisciplinary team to take care of women and girls with bleeding disorders? Is your knowledge very poor, poor, fair, good, very good, or excellent? So we'll give it just a second so that you can fill those questions out. And then in the back room, if you want to go to the next slide, when you think we're ready to do that, we'll get into our program. I would really like to thank our sponsors for the program. This event is made possible through the generous support of the Hemophilia of Georgia and the National Hemophilia Foundation. here are a picture of our speakers. I will take the time to introduce each speaker as we get to them. And our first session, Fertility Issues in Women and Girls with Bleeding Disorders, OBGYN Point of View, will be covered by Dr. Maureen Baldwin. And this will be our very first presentation. Dr. Baldwin is Associate Professor of Obstetrics and Gynecology at OHSU in Portland, Oregon. Dr. Baldwin is a co-director of interdisciplinary hematology and gynecology adolescent clinic called Spots, Dots, and Clots, which treats teens with heavy menstrual bleeding. Her research has focused on hormonal management of menstruation, pregnancy loss, abortion safety, system approaches to contraceptive access, and teaching with simulation. Please go ahead.
Hello, everybody. I'm Dr. Maureen Baldwin. I'm an OBGYN from Oregon in the United States, and I'm going to just review fertility issues in women and girls with bleeding disorders, specifically around reproductive years. These are my disclosures. So the normal fertility cycle in reproductive years is impacted and very different for people with blood disorders. There are specifically bleeding risks during pregnancy, as well as considerations for the fetus. And this starts prior to pregnancy, even at preconception, which is a very important time. There are some considerations around the time of conception and early pregnancy, as well as different strategies we use to assess fetal development and status. And then there are the impacts of normal obstetric disorders on bleeding disorders. There are certainly more concerns about risks for labor and delivery with people with blood disorders, and then assessment postpartum. So the fertility cycle is all of these stages from preconception, conception, early pregnancy, fetal status, obstetric monitoring, labor and delivery, and postpartum. And then the interpregnancy interval, or the time between postpartum and conception, is again preconception. So it just keeps going around if you have more pregnancies. And this doesn't take into account the early consideration of pregnancy timing after someone has their first period, and all the time of contraception that needs to happen before it's time to have a baby. And it also doesn't take into account after family building is complete and there are no more pregnancies desired until menopause. So we'll just talk about what's specific for the time around reproductive years. So for someone with a blood disorder, around the time of preconception, it's very important to establish obstetric care. And this does a number of things, including make sure that you have access to a clinic, as well as discuss certain topics. Also very important to have a discussion with a genetic counselor prior to conception, if possible. During early pregnancy, any complications or concerns really do need specialty level care. And this means meeting with an OBGYN rather than a midwife, or being cared for even in a specific type of location. Fetal assessments during pregnancy for genetic status in some cases, or testing, also need to be considered. And then when getting ready for delivery, thinking about where the delivery will happen and the timing of delivery and all the preparation that needs to happen to get ready to reduce blood loss at the time of delivery is important to consider. And that includes preventive strategies during labor, as well as treatment strategies, and making sure that they're available. Following the birth, also there are considerations for prevention of extra bleeding. So this whole time during pregnancy and during the cycle, we're thinking about the bleeding risk status. And the risk status for someone with a blood disorder is generally similar to someone without a blood disorder, but then compounded by their blood disorder. So it means that while they're having a miscarriage, they may be at risk for bleeding, but with a blood disorder, that bleeding could be significantly more. The typical bleeding risks during pregnancy in the first trimester are with implantation bleeding or a subchorionic hemorrhage, and that can be a higher risk for somebody with a blood disorder at the time of miscarriage or during abortion, and also during normal procedures such as genetic testing using chorionic villus sampling. There can be additional bleeding that might need prophylaxis. In second trimester, Other genetic testing such as amniocentesis would be a consideration for a bleeding risk, pregnancy loss, abortion, and also procedures that are unrelated to a bleeding disorder such as cerclage or the tightening or stitch in the cervix if somebody is having a cervix that isn't wanting to stay closed. So those are all procedures that can cause extra bleeding. In the third trimester, of course, labor, a C-section, surgical birth or vaginal birth are things we always think about being related to pregnancy. Following the birth, there can be issues including retained placenta that would increase bleeding, or obstetric laceration, such as a laceration or cut to the vagina during the birth that could bleed more for somebody who has a blood disorder. And then the normal postpartum bleeding or the recovery of the uterine lining, which is called lochia, can also be more for somebody with a blood disorder. In the preconception visit, really the most important thing, especially in the United States where we don't have comprehensive medical care, is to establish care with a practice to ensure access if something were to happen prior to the very first appointment. And additionally, there are many topics, and I think a lot of people don't think about having this type of a visit, but it can be really helpful to prepare for pregnancy. So a visit dedicated to optimizing health, including discussion of topics related to not just the blood disorder, but also genetic counseling or carrier screening related to the blood disorder, getting immunizations up to date prior to pregnancy, making sure we know the blood type and do an antibody screen to make sure that any prior transfusions wouldn't impact the pregnancy. And then general health, so optimizing weight and exercise and nutrition, optimizing iron repletion to make sure there's no iron deficiency going into pregnancy. Additionally, sometimes we talk about how to get pregnant or the timing of pregnancy. Sometimes getting pregnant for someone with a blood disorder means stopping their menstrual management medications, which can lead to heavier periods. And so the time that we would allow someone to continue to try really hard to get pregnant might be shorter than with a blood disorder than not, just so we can really look into that source of difficulty while they're not continue to have periods. We'll also talk about medication and environmental health safety and recommend starting prenatal vitamins prior to pregnancy. A hematology preconception visit will include a discussion of the inheritance of the bleeding disorder, might test factor levels before pregnancy and discuss expected changes in the factor levels, talk about factor use in pregnancy and whatever prophylaxis were previously being used, the safety of that related to pregnancy, and the tranexamic acid in pregnancy, which is generally considered safe. Charting cycles and knowing your last menstrual period prior to conception is very important to be able to determine how far along the pregnancy is. And then with a positive pregnancy test, we recommend contacting both the obstetrician and the hematologist that you've already established with. We recommend calling with any bleeding, even though not all bleeding is miscarriage, and most bleeding is very light and stops quickly, even for someone with a blood disorder. But it's just important for us to be able to chart when that's happening. We aim for the first visit typically around 6 to 8 weeks, but if there's bleeding or need for a different evaluation for another problem, then we'll see patients earlier than that. In early pregnancy, miscarriage occurs in about 20% of pregnancies, and usually those occur before 10 weeks, most of them before 6 weeks, and the rate is not known to be higher in people with blood disorders. However, if someone starts having a little bit of bleeding and that little bit of bleeding turns into a lot more bleeding for someone with a blood disorder, that could worsen the risk of pregnancy loss. Many people with pregnancy loss actually have no bleeding at all and still have signs of pregnancy. So an early ultrasound to assess the viability of the pregnancy is really important. And the reason for that is that having a pregnancy loss spontaneously at home can be a lot more dramatic and difficult for somebody with a bleeding disorder than having it in a controlled environment. And generally, rather than allowing somebody to pass a pregnancy at home or to take medications to help pass a pregnancy, we would usually advise an office or sedated procedure to evacuate the pregnancy, known as a suction D&C. Suction D&Cs have a normal blood loss of about 50 to 200 milliliters, and it can be a slightly larger amount for someone with a bleeding disorder. But in that controlled environment, it's considered very safe, and most people can undergo this procedure as an outpatient in a clinic setting where they're used to doing that. We do think that sometimes preventive medications like factor or tranexamic acid or another antifibrinolytic could be helpful in the outpatient setting or even in the operating room for prevention of extra bleeding. When we think about assessing the fetus throughout pregnancy, there are several stop points, and in the United States, typically they look like this. We typically recommend genetic screening or testing anywhere throughout the pregnancy through non-invasive testing, but more timed would be usually an early ultrasound around 13 weeks to look at the fetal nuchal translucency or the thickness of the back of the neck, a specified measurement that helps us know if there might be higher risk for genetic abnormalities or cardiac abnormalities. Additionally, we recommend an anatomy evaluation around 20 weeks gestation, and then growth and viability assessments depending on other risk factors, potentially every month or just once, or maybe not needed at all. And then another important component of fetal assessment would be a pre-delivery consultation. So if we know that the fetus is likely to be affected with a blood disorder, we will want a plan in place with the pediatrician, and that usually involves having a consultation before delivery. Many obstetric disorders can arise during pregnancy that are completely unrelated to the blood disorder, but can really compound it. And these are some of the ones that can compound a blood disorder and make the situation worse. So for example, hypertensive disorders like preeclampsia or gestational hypertension can result in an earlier delivery, may need to require inpatient observation, can impair the liver in some cases and lead to hemolysis, all of which can make a blood disorder more complicated. Thrombocytopenia or low platelets can occur in pregnancy normally, lowering the platelets down to a threshold of about even 90 to 120,000. And this is not typically a functional problem, but in light of other platelet disorders could make things worse. And then we also think about the placenta, and having had prior uterine surgeries such as multiple cesarean deliveries can lead to abnormal implantation of the placenta, leading to extra bleeding or difficulty removing the placenta at the time of the delivery. And this is something that typically can be observed on ultrasound prior to the delivery so that we can be ready for it, but is not always able to be recognized early. Additionally, early separation of the placenta could lead to abruption, which is extra bleeding from the pregnant person, and could lead to a lot of bleeding at once unless it's treated quickly with delivery. So we have all these other components contributing to potentially extra bleeding or difficulty. When we're getting ready for delivery and we don't expect any problems, hematology preparation will usually give consultation advice, mainly about the infant. So thinking about cord blood sampling to obtain factor levels immediately, avoiding injections to the fetus initially, avoiding circumcision until evaluation has been complete, and an early pediatric hematology evaluation. And they'll also give recommendations for obstetric management as well, including timing of factor administration and prophylaxis for bleeding. For the obstetric management side, it requires a team approach with the hematologist and also the anesthesiologist, really being ready ahead of time to manage any difficult situations. So this does require delivery in a hospital where there can be transfusion, including factor administration if needed. Sometimes this is better facilitated with a timed delivery and also with timed prophylaxis, such as administering factor at a certain timing before delivery. And that can make it a little bit difficult to know exactly when somebody's going to deliver. I've had hematologists tell me, I think you should give her factor 30 minutes before delivery. And I said, well, tell me when that is if you think you can figure it out. Sometimes it's not always so easy to know. We also do some different things during labor management. We avoid invasive monitoring, including avoiding putting a little clip on the fetal scalp, which we sometimes use to monitor fetal heart rate. And we, in considering route of delivery, typically the plan is vaginal birth, but we do try to avoid any forceps or vacuum assisted deliveries. And then I mentioned timing of prophylaxis can be the most challenging, but typically we do utilize tranexamic acid or antifibrinolytics really frequently, and then other non-hematologic medications, including uterotonics or medications that can help the uterus squeeze down to avoid extra bleeding. Obstetric hemorrhage has a lot of potential reasons, and only one of them is coagulopathy, or the problem of the blood clotting. The biggest reason for obstetric hemorrhage is atony to the uterus, which means that the uterus is failing to squeeze down as a muscle and stop the blood vessels from bleeding. It can occur from infection. Uterine atony can also occur after a very long labor, and also a very stretched out uterus might be more prone to atony, such as with twins or multiple gestation. Other reasons for bleeding include laceration or just surgical bleeding during a cesarean delivery, retained placenta, as I mentioned before, or morbidly adherent placenta that is really stuck and invaded into the wall of the uterus. Initial management for hemorrhage will include, exam to rule out any of these causes, to make sure the uterus is empty after the birth, check blood pressure and monitor status of the patient. And then the next step is to massage the uterus to see if we can get it to squeeze down more. We also explore the inside of the uterus to make sure everything is out, because even one little bit of membrane or particle of the placenta can avoid the uterus squeezing down where it should be. And then we give medications to help the uterus squeeze even more. Usually those are injections, sometimes they're intravenous. And then we might also put something inside the uterus to help squeeze from the inside out. And I'll show you some pictures of some of those devices. And then we'll, of course, be resuscitating the patient, making sure that they have blood transfusion if needed, and enough fluid management to keep their status good. So this is a dramatic picture of a massage of the uterus, and following delivery, if we need to help the uterus squeeze down so that both sides of the uterine walls oppose each other and cut off the blood flow that's coming out from where the placenta was attached, we often will need to place one hand above and one hand below to help squeeze the uterine walls together. And this is one of the most effective ways, very low resource, not very many supplies needed, to be able to help stop bleeding. Another device is a uterine balloon, and there are many different versions of this kind of balloon. Balloon is placed into the uterine cavity and then inflated with saline, and the walls of the balloon push outward on the uterine walls, doing the same thing we would have tried to do to squeeze the walls together. Just pushing on those walls will help reduce the blood flow. And there are other new devices, including this system called JADA, where there's suction applied to a device inside the uterine walls to help squeeze them together from the inside. Postpartum, after everything is finished and the baby is born and the placenta is out and there either was or wasn't extra bleeding at the birth, we expect there to be small clots and needing really large pads. Having extra bleeding after a birth is very normal. And this can be really difficult to determine for someone with a blood disorder, whether you're in the normal range or not, because there are all kinds of colors of the blood: dark red, bright red, yellowish green. It can increase with nursing, it can increase with movement. Generally, it's decreasing over time, but it does last up to 3 to 4 weeks. And so if this is even just a little bit more than normal, it can actually lead to more blood loss for someone with a blood disorder. And so many times we'll want to give preventive medications like antifibrinolytics or tranexamic acid, or even factor. Factor levels do return to baseline pretty quickly after the birth, and so we would hope that we can be checking those and be monitoring for whether that's impacting bleeding. What's not normal is having big gushes of blood, and that's one thing we really emphasize to patients. So if you bend over and you have a big gush come out, that's very unusual. It could mean there's retained tissue inside the uterus, and that could be a risk factor for having heavier postpartum hemorrhage. Also, having large clots is abnormal, or filling 2 big pads in an hour. The main points to impart are that preconception health is vital to optimal healthcare, mainly because it helps establish care and get the information before pregnancy. And that most bleeding with birth is due to a relaxed uterus or uterine atony. And the best treatments for those are actually not factor and blood transfusion, but squeezing the uterus. The bleeding disorder is only one of the many risk factors for bleeding with birth. Timing factor administration to birth is really challenging, and we do our best, but that recommendation is something we always have to work as a team to achieve. Thank you so much for your attention, and I'll turn it back to the program administrator. Thank you.
Thank you so much, Dr. Baldwin. That was excellent in such a short amount of time. You really covered a lot of topics. If we could go to the next slide, please. Thank you so much. I am very excited to welcome our next presenter who is live with us today. So thank you so much, Marion. Marion Brewer has severe factor VII deficiency and has been active in the bleeding disorders community for several years. She is on the board of the Austrian Hemophilia Society and also in the European Hemophilia Consortium Women and Bleeding Disorders Committee. She works as a graphic designer and likes reading, listening to podcasts, and yoga. Marianne, thank you so much for being here with us.
Thank you, and hello, everyone. Could we go to my next slide, please? So I will be talking about myself a little bit more and about my factor VII deficiency, and then I will come to the gynecological and fertility issues. Next slide, please. Yeah, Dawn already said it very nicely. So I'm from Austria, I'm 35 years old, and on the pictures you can see me with various bleeds, mostly in hospital. So yeah, I have some experience with that. Next slide, please. Thank you. So about my factor deficiency, I was diagnosed when I was 3 months old. There I had my first bleed. The back of my hand got swollen and my parents didn't know why. So they went to the hospital. And yeah, that was when I got my diagnosis quite early. It was quite a surprise for my parents to find out they had both lower factor levels and that therefore I had the severe form. So they did not know before. And I get factor concentrated since then. The first years I got on-demand treatment. When we could measure the bleeding in my swollen arm or leg or wherever, then I would get the factor. It has a very short half-life of about 3 to 4 hours. So I have a lot of experience with bleeds and hospitals. And in primary school, I started to get prophylaxis 3 times a week and later even every second day. And my bleeding rate went down immensely. That was great. I told you before, both of my parents had lower factor levels. So the inheritance pattern of factor VII deficiency is called autosomal recessive. I hope I'm saying that correctly, which means for a child to have the severe form, both parents have to be affected. Otherwise, the child can only get the milder form. Which brings me to the gynecological and fertility part. Next slide, please. Let me start with the not so pleasant topic of gynecological bleeds. It took me about 30 years, like 30, to realize that my period was too heavy. I mean, there were clues, like sometimes on my way to school, which took me around an hour, I bled through my sanitary pads, and that was embarrassing, as you can imagine. It also happened later at work sometimes. And I also had to deal with iron deficiency and even anemia. I tried various contraceptive methods, but nothing really worked in my case. But what helped me though was the 7-2-1 rule, or you can also call it 7-2-2 rule, but I'll get to that. If the period lasts longer than 7 days, or you need to change your sanitary products every 2 hours or more often, which I had to, or you have blood clots bigger than a €1 coin, but I measured it since you probably don't use euros. The coin has a bit more than 2 centimeters in diameter. So it's either 7-2-2 or 7-2-1. Then your period is too heavy. And knowing that really helped me a lot. So since then, I started to inject every day on my heavy days. And also additionally, I use tranexamic acid if it's available. And my quality of life got better, a lot better. Besides the heavy periods, I also regularly have cysts in my ovaries. Usually they come and go as they please, but sometimes a cyst gets blood-filled and then sometimes it bursts, which is really painful. But luckily that doesn't happen often. I also have other bleeds, but I will not go into detail here. Next slide, please. Thanks. So now you know me inside out, kind of. But what you don't know yet is whether I want kids or not. And I'm telling you, I do. I knew from early on that I wanted to have kids one day, but later. With my bleeding history and the short half-life of the factor, the actual decision to give it a try was quite hard for me. So when I turned 30, my previous hematologist encouraged me to come to a decision, best before turning 34. But I had just met my new boyfriend a few weeks before, so I was really stressed out. And then I decided to be very honest with him, and I told him about my situation and that I didn't know what I wanted at that time, and we decided to wait and to see how we work out together. And we had numerous conversations together with others about experiences, about risks, about dreams. It was a hard decision. And after 3 years, I had my copper coil removed, and then we decided to stop contraception and to finally give it a try. I was happy about that. I was expecting to get pregnant every month, but during the next year, nothing happened. Well, not nothing. I learned even more about my body, about fertile days, about how irregular my cycle actually is. And the next time I went to my gynecologist, she told me that my follicle numbers were getting really low for my age. So I didn't have much eggs left, so to say. And she advised us to go to a fertility clinic if we wanted to continue. She also told us that it's not going to be easy to conceive. I don't know if that's due to previous cysts or bleeds or not, but it was kind of a shock to me. I had heard that fertility treatment can have potential bleeding risks. So first I didn't know what to do, but then we decided to make an appointment at the fertility clinic at my treatment center, just to collect all the information and then come to a decision. So we got that appointment. A few months later, we had to wait for some months. And I had also talked to my hematologist about becoming a mother beforehand. He was very supportive, and he told me that I should increase my injections as soon as I knew I was pregnant and then contact him immediately. And I asked him if we could do pharmacokinetics, which means I had blood samples taken to see how my factor level is increasing and then decreasing again, in which time span, because of the short half-life. So we had an idea of how much factor I have after 2 hours, 4 hours, 6 hours, and so on. And I also started checking my iron levels very regularly to avoid iron deficiency. The month passed by, and on the weekend before our appointment at the fertility clinic, the app that I used to track my cycle told me that my period was late, which happens sometimes with my irregular cycle. I made a pregnancy test just in case. I had done that before and they were always negative, so I wasn't expecting anything anymore. But this time, a faint line appeared, which meant I was pregnant. Oh my God. Next slide, please. Yeah, that was quite a surprise. At first, we were so confused. We even locked ourselves out of our apartment at that day. And after realizing it all, I made it to my doctor, and yeah, we made an appointment, and our appointment at the fertility clinic was quite short. They just confirmed an early pregnancy. And then I met with my hematologist. I had a bleeding at that time, so he advised me to inject every day and double my dose. And the aim was to always have some factor level for reducing the risk of losing the baby, which of course can always happen, as we know. Now I'm 20 weeks pregnant. Half of the pregnancy is accomplished today on International Women's Day. I love that. But to be honest, sometimes it's also scary, and the injecting is hard because of my bad vein situation. But I'm really thankful that I'm able to experience this. I know this is very privileged, especially in my condition. So what I've learned is that good information and medical care are essential for us. But I also learned that it needs a lot of courage and also support from others to make this happen. It's not a one-woman show. So coming to the end of my talk, I want to introduce you to the principles of care for women and girls with bleeding disorders. I recommend that you go through the principles, take them with you, and use them to advocate for yourself in your clinic or at your doctor's. Next slide, please. I hope that my experiences were useful for you and can help you aim for the best treatment and quality of life possible. Thank you for your attention.
Marian, now I'm all misty and weepy. Congratulations.
Thanks. I'm so happy. Thank you.
Okay, side note for all of our audience, I just want to take a minute to wish you the very, very, very best. That is such exciting news. I know you've been on such a journey. Okay, well,
thank you.
Wasn't expecting that. So let's go to our next slide and our next presenter. Claudia, you have some shoes to fill here. I am so happy to welcome and introduce Dr. Claudia Diambas-Kayat. She's the pediatric hematologist, member of the WGBD and Rare Bleeding Disorders Committee of the World Federation of Hemophilia. She is professor of pediatrics and chief of pediatrics at St. Joseph University in Beirut, Lebanon. She developed as medical advisor of the Lebanese Hemophilia Association, a 3-year national program for the improvement of hemophilia care in Lebanon and a screening program for bleeding disorders. She oversees the National Data Registry and member of the Lebanese National Committee of Hemophilia and Bleeding Disorders. Dr. Kayat, it is my pleasure to welcome you. Please take it away.
Hello, everyone. Thanks a lot for the presentation. What I want to ask you is, why are we talking about this topic today in the Women's Days? I think that bleeding disorder affect men and women, but we speak of this topic today because bleeding disorder pose unique problems for women. It impacts on quality of life and it impacts on their reproductive health. Current data estimates that as many as 1% of women in the United States may have a bleeding disorder, and many are unaware of their condition. And what is more important is that undiagnosed women have disparity of care and fertility that could be life-threatening. Effectively, if we look around the world, maternal mortality ratio is not very good. Perhaps in the States and Europe, you will have good data, but in the other part of the world, there is a lot to do. In fact, a woman dies of pregnancy-related cause every 2 minutes, and this is terrible in my point of view. If you look to the main cause of maternal death in Latin America and the Caribbean, we see that more than 1 out of 5 women maternal deaths are from hemorrhage. And effectively, looking to the
To our background people, did you also lose connection?
I have a problem.
Okay, we can hear you again.
Yeah, you can
back.
hear me, but I cannot get my slides ahead. It stopped. It's fridged.
Oh,
I'm
okay.
sorry.
No problem. Stop sharing. And then what we'll
Okay.
do is ask the WFH team to go ahead and share your slides, and then you can just say next slide.
Okay, stop sharing.
Yes, please.
Like this. I'm sorry.
Oh, no problem.
In fact, the current get cut in the country. That's why we have problem.
Yes, no problem. Is your screen still frozen on your end?
Yes, I'm still
Okay.
frozen.
WFH team, can you stop her sharing and take over the slide part? Thank you. And then go ahead and share your slides. Perfect. And there we go.
Okay. Can I have the next slide, please? The next one. The next one. Okay. Talking about undiagnosed women, I want to share with you some clinical case presentation to show you the problem they can face. The first presentation I want to have with you is a 20-year-old lady referred to hematology consultation for severe postpartum bleeding. In fact, she came to the consultation saying that she don't understand what we sent her for this consultation, because I already told her that she do not have any bleeding disorder. When you take history, we discover that we have easy bruising since birth. She had prolonged and painful menstruation bleeding that impair her quality of life. She had pelvic pain, usually worse during period, and family history of heavy.
I think Dr. Kayat is having some internet issues.
And
there she's back.
She was diagnosed as a... Next slide, please. Okay. Getting pregnant was difficult for her, and last year she had a cilioscopy that returned normal. At the end, pregnancy was successful after several attempts, and in one of the attempts, she received aspirin in the first trimester, and this attempt was solved with hemorrhagic miscarriage that need blood transfusion. Coagulation work done by gynecologists following all this issue showed a normal TP and APTT, and patient was reassured concerning coagulation. Then, during the last pregnancy, because of the atypical history, anesthesiologist performed her von Willebrand factor activity at the third trimester, and it returned normal. Unfortunately, she delivered in another hospital. Anyhow, delivery went well, but next slide, please. 4 days after delivery, she presented profuse vaginal bleed. She was admitted at hospital for hypovolemic shock after 24 hours of her vaginal bleed. Postpartum hemorrhage was diagnosed. All medical treatment failed, and an hysterectomy was performed. And at the end, when we reevaluate the patient, she had von Willebrand type 1 disease. Next slide, please. So what do we learn from this clinical study? First of all, she was unaware of her disease, and she is not an isolated case. When you look in the map world, we know that the prevalence of von Willebrand in general population is estimated at 0.6 to 1.3%, and the prevalence of symptomatic patients that require specific treatment are like 1 over 10,000. But if you look to the map world, a lot of area did not diagnose the von Willebrand disease yet. Next slide, please. Why von Willebrand are underrepresentative? There is a lot of obstacles, perhaps because of lack of national registry, lack of tool of diagnosis in the world, complexity and breadth of tests required for the proper diagnosis, lack of adequate treatment, because only severe patients ask for help, but also because perhaps lack of awareness of problem by women themselves, what is normal. In this case, all the family are bleeder, so she thinks that it could be normal. Long-term problem of menorrhagia may be regarded as normal, and positive family history may uniquely reinforce this idea. Failure of healthcare professionals to think of the possibility of underlying the bleeding disorder, tendency to look for physical condition such as fibroid in women, full medical history not always elicited, and referrals discouraged after run of negative case in some case. Next slide, please. So I would say that it's urgent to have public, patient, and medical awareness. It's highly needed, and you have to work on it. Next slide, please. Second idea is that she had normal TP and PTT. We have to remember that normal TP and PTT do not exclude von Willebrand disease. Whenever there is a suspicion of bleeding disorder, we have to ask for von Willebrand activity, as it's the most frequent disease, and von Willebrand activity must be done more than once. And when for having a suspicion, either you have a validated bleeding score more than 5, or a high score for menstrual bleeding, either you take a PBAC score of more than 185, or the 7 to 1 suggesting of heavy menstruation. Next slide, please. Second, third things, what we have to remember and know is that we have hemostatic change in pregnancy. Normal pregnancy is accompanied by an increase in fibrinogen, factor 7, 8, 10, and von Willebrand factor and pi. This change leads to a normalization of hemostatic effect in some bleeding disorder. Factor 2, 5, 9, and 13 are relatively unchanged. Protein S is decreased. Next slide, please. For von Willebrand, for example, as it's the case of our girl, type 1 factor von Willebrand and factor 8 could achieve normal level at the 3rd trimester. Type 2 antigen and factor 8 increase, but activity do not change. And at 3, there is no change. Next slide, please. And what is most important is that if factor von Willebrand look normal at birth, after 3 days, it dropped dramatically, and we can have easily a bleed. Next slide, please. Concerning postpartum hemorrhage, what we have to keep in mind is the quickest of maternal killer. It occurs in about 1 to 10% of pregnancy. Most common cause, as you already heard, is perhaps urine atony, but bleeding clotting condition is important also. Treatment rely on several issues. We already hear it in the first presentation, but unfortunately, we can have until now hysterectomy done, and this is really a pity. Next slide, please. Now I want to share with you a second case presentation. It's a young woman, 20 years old, wanting to get pregnant. She has several unsuccessful attempts, several miscarriages. When you look on history, easy bruising, menstrual bleeding described by patient as normal, recurrent problem of iron deficiency anemia. There is familial history of thrombosis. And when she go to obstetric consult, because she wants to get pregnant, they give her low aspirin treatment. Next slide, please. At 8 weeks of gestation, she had an important vaginal bleed and miscarriage with a hemoglobin drop of 5 grams. She was transfused with packed red blood cells and fresh frozen plasma. Then she was evaluated, and we discovered that she had severe fibrinogenemia. 1 week after miscarriage, she had dyspnea and pain chest, and she presented pulmonary embolism. And then she was treated with low molecular heparin and fibrinogen concentrate. Next slide, please. What did we learn from this clinical case? We know that there is pregnancy risk in afibrinogenemia and hypofibrinogenemia, like miscarriage, retroplacental bleed, intrauterine growth retardation, vaginal bleed, postpartum hemorrhage, and thrombosis. Next slide, please. Effectively, miscarriage, there is perhaps lack of data in the literature to determine risk of bleeding and pregnancy loss during the 3rd trimester in women with bleeding disorder. But what is certain is that we have problem with afibrinogenemia, hypofibrinogenemia, and factor 13 deficiency, as you see in this table. Next slide, please. Although for when you have a woman with bleeding disorder with hypofibrinogenemia or afibrinogenemia, there is no consensus on the optimal value during pregnancy or in the peripartum period of the fibrinogen level. But it is suggested that the fibrinogen level should be maintained around 0.5 to 0.6 gram per liter as minimum during pregnancy, and a minimum of 1 to 1.5 during labor. Next slide, please. What we know also is that up to 20% of patients with afibrinogenemia experience thrombotic events. We know also from different studies that there is high probability of thrombosis in dysfibrinogenemia. And I think that fibrinogen disease had to be considered as thrombotic risk factor, and you have to consider mechanical or pharmacological prevention of thrombosis. Next slide, please. What I want to tell you from this clinical presentation is that this clinical situation could be avoided with the right diagnosis on good time, with the right care at the right time. So it's a pity. And next slide, please. To have this right thing done, a multidisciplinary teamwork and network is needed. When I mean multidisciplinary team, it's a team formed with various persons, a gynecologist, a midwife,
I know we've lost audio. I'm hoping she comes right back.
nurse, physiotherapist, hematologist, nurses to implement adequate management at the right time. Patient had to be active member on this time. He is the driving wheel of the team. And for this, we have to empower the patient. It's highly needed. Last slide, please. Can I have the last slide? And this must lead this disciplinary team. The success of this multidisciplinary team is working together, not looking to the patient, but looking to the success of the patient that need integration to society, active member of society, normal life, and we do not need to see any more being the silent majority. Thanks a lot. I finished.
Thank you so much, Dr. Kayat. That was excellent. I actually learned so much. I have I'm just scribbling notes like crazy. So I'm very excited that these webinars are recorded, because I don't know about you all, but I definitely will be going back and watching again. Thank you so much. Let's go ahead and go to the next slide. So we really want to test what you learned today. Please rate your knowledge again in the following areas. We hope that you did learn something from our presentation. So the very first question is bleeding risks during pregnancy for women and girls with bleeding disorders. What is your knowledge now that you've watched the webinar? Very poor, poor, fair, good, very good, or excellent. And then hopefully you were paying attention, because we definitely, Marian covered the 722 rule, or in some cases the 721 rule, but we know it as the 722 rule. Very poor, poor, fair, good, very good, or excellent. Number 3, main causes of maternal death. This was definitely covered. I hope that you learned a little bit. And what is your knowledge now? Very poor, poor, fair, good, very good, or excellent. Question 4 is the menstrual bleeding assessment PBAC score. What do you know about it now? Very poor, poor, fair, good, very good, or excellent. And then finally, please rate your knowledge and skills in the multidisciplinary team management. Very poor, poor, fair, good, very good, and excellent. We'll give you just a moment to complete these. And then we'll be able to do a few minutes of the Q&A. And I know there are a lot of questions in the chat, so I'm not sure we'll be, or in the Q&A, not sure we'll be able to get to all of them. So please make sure that you submit your questions in the Q&A box. I saw a note in the Q&A that said, hey, we can't use the chat. That's exactly right. Please go ahead and put your questions or comments in the Q&A box at the bottom of your phone or your computer. And with that, I think we're ready to bring our panelists to the screen. So if yes, thank you. And Marion, if you could turn on your camera as well. So unfortunately, Dr. Baldwin was not able to join us for the live Q&A, and I just thank her so much for presenting with us today, but I know she's traveling. And so for our Q&A, I'm going to go way back to the very beginning. And oh, okay, this is wonderful. So these are our results in the poll. Hopefully everyone can see this. This just popped up. So it looks like our panelists, you did a phenomenal job. It looks like there were a lot of really good learnings happening today. So thank you. So the very first question, and Claudia, I'm not sure if you can answer this, but you may have had some experience with this as a hematologist, but are water birth and home birth advisable for women and girls with bleeding disorders? This is trending now, and so there are a lot of questions about that.
I will not advise to do home birth, certainly not, because we never know with
Oh, unfortunately, her audio froze again.
Yeah, but maybe I can finish the sentence because I guess.
Oh, sorry, Claudia, your audio cut out. If you would like to continue, we heard it's not advisable, but
it's not advisable because it's high risky pregnancy, and not only for women but also for children who will be born. I think we need to have a multidisciplinary team around to have a good issue for pregnancy.
Nothing to add here. Sounds good.
Okay.
Sounds perfect.
Thank you so much. So how come a coagulation factor test or an activated partial thromboplastin time, APTT test, is not part of the required test for pregnant women? Having this test as a requirement could potentially detect bleeding disorders if unknown prior to conceiving a child and presenting disastrous bleeding at delivery.
I think that if we take a good history and a good bleeding score in a woman, we could think that there is a problem. For example, the case I present, the APTT was normal and she had problem. So I think APTT alone is not enough if we rely only on APTT. The most important thing is a bleeding score that must be taken, either the self-bleeding score or the bleeding score done by physician. But it is important to think about bleeding disorder and to look, and this is part of the awareness we have to do and to work on it around.
Thank you. Another question comes in, and then Marion, I promise we'll get some comments for you as well. Does pushing the uterus result in bruises internally?
I didn't understand the question, sorry.
I'm sorry. Does pushing the uterus, so when Dr. Baldwin was talking in her presentation about trying to push the uterus, she showed a picture, a very graphic picture of the fist inside and then on the outside pushing the uterus together to stop the bleeding. The question was, does that cause internal bruising?
I don't think it will cause internal bruising. It's a way to stop the bleed. We use it to stop the bleed. It's a compression. It will not be harmful inside. It's a pressure, just a pressure to clot, not clot the vessel, but it will not be harmful. No.
Thank you. Thank you. That's really helpful because I was wondering the same. You might stop the uterine bleeding, but then maybe cause other issues. So that's very helpful. Marian, I just have to tell you how many comments came in during your presentation with your big reveal at the end. It was so lovely. And there's just so many. I hope you can read through the Q&A because there have been so many incredible congratulations and sending love and very best wishes to you. So I just wanted to shout that out. Everyone is so excited.
Thanks.
Absolutely. So another question came, I greet you from Mexico. Is the use of cryoprecipitates indicated for obstetric hemorrhage in the absence of coagulation factors and tranexamic acid? And what would be the starting dose?
I think that cryoprecipitate, if you have nothing else, is better than nothing.
Yes.
But it's not the best treatment you can choose. In cryoprecipitate, you have fibrinogen, and we know that fibrinogen is really important for postpartum bleeding. To give you the dosage, we don't use it, so I cannot answer you immediately. But certainly we can use cryoprecipitate. It's not. It's better than something else, certainly.
Thank you very much. Can contraceptives be used to reduce bleeding and factor VII deficiency? Marian, do you want to talk about your experience?
Yeah, I mean, I guess they can, but in my experience, they did not have help. I tried various contraceptive methods, but in the end, I decided to use the copper coil because I wanted to stop hormonal treatment and see how this is working for me. But before that, I tried various hormonal contraceptives, and I guess it's worth a try. Mm-hmm. But you need some patience, and also you need to get the right dose, and it's not easy. But I guess it can help, but it doesn't have to. So,
absolutely. So I know we are at time, and I want to be very respectful. We have a ton of questions left to answer in the Q&A, but I really want to be respectful of everyone's time. We'll do our best to answer those questions and be able to post with this webinar. It will be posted. I did want to shout out a couple of things. Thanks to Brian Amahani for posting. He was trying to post an infographic from the Irish Hemophilia Society on the 721 rule. And they have a really lovely graphic. So if you go to the Irish Hemophilia Society website, you should be able to pull that graphic. So Brian, thank you for sharing that or trying to share that. And then also I wanted to shout out to Emily, who's a manager of the World Federation Bleeding Disorders Registry. She did type this in the chat, but our registry collects data on women and girls with bleeding disorders, specifically females with hemophilia and VWD, and she put a link in the chat for you all to access. Please, if you are with a hemophilia treatment center, or if you are with an NMO, please consider trying to participate in those registries, because as Claudia was mentioning, we don't have data on so much of the work that we're trying to do. And without data, we can't get access to treatment and care. I want to thank Dr. Kayat and Marian and Dr. Baldwin for presenting today. Thank you all for your time. Go hug somebody and have a wonderful rest of your day and celebrate International Women's Day together. Thank you all.
Thank you.
I'd like to also say, please support free webinars like this one today by making a contribution. You can scan the QR code or visit give.wfh.org. We want to make sure all of these webinars are accessible for everyone living throughout the world. And so with your help, we can make that difference. Thank you.